Here is the structured content based on Chapter 17, Immediate Dentures, from the provided textbook pages. Immediate Dentures. Introduction. Patients who have extracted all of their natural teeth in one or both jaws have to wait for at least 6 to 8 weeks after teeth are extracted before conventional complete denture can be fabricated. The extraction sites heal during this period, accompanied by a rapid period of alveolar bone remodeling. Consequently, the patient suffers the social indignity and functional difficulty of going without teeth for several weeks. The immediate denture offers a solution to this problem because it is constructed before and placed immediately following the extraction of natural teeth. It is more challenging than conventional dentures because a try-in is not possible to verify the arrangement of anterior artificial teeth. Definition and types. Two types of immediate dentures are recognized: conventional immediate denture, interim immediate denture. Immediate denture: any removable dental prosthesis fabricated for placement immediately following the removal of a natural tooth, teeth, GPT-8. Interim denture: a removable dental prosthesis designed to enhance aesthetics, stabilization and/or function for a limited period of time, after which it is to be replaced by a definitive prosthesis. Conventional versus interim indications. Conventional immediate denture, indicated when only the anterior teeth remain and posterior residual ridges are well healed. Following extraction of anterior teeth, an immediate denture is provided, which only needs to be relined after the healing period. Interim immediate denture, indicated when both anterior and posterior teeth are to be extracted at the same time and immediate dentures are provided. New complete dentures are fabricated after the healing period. Advantages and disadvantages. Advantages. Maintenance of patient's appearance as they are not without teeth even for one day. Acts as a bandage or splint to control bleeding. Less postoperative pain as extraction site is protected. Vertical dimension, jaw relationship, muscle tone, face height and tongue position are maintained. Speech and chewing habits and digestive function are not compromised and nutrition is maintained. Adjustment to the new dentures is quicker than with conventional complete dentures. Patient's social, professional and psychological status is not hampered. Artificial teeth can be arranged in same position occupied by the natural teeth. There is less resorption and better preservation of residual ridges as they are subjected to early function. The ridges are better adapted to support a denture. Disadvantages. Anterior try-in is not possible. Patient has no idea how the denture will look on the day of insertion. Requires more chairside time, additional appointments and cost. Bone resorption and shrinkage of unhealed soft tissues is greater and faster than the changes in healed tissues. These changes may require frequent relining. As the jaw relations are recorded with the natural teeth in varying numbers and locations, inaccurate centric and vertical records are possible. Cannot restore the stimulation that was supplied to bone by the natural teeth. Anterior ridge undercut, commonly present when only anterior teeth remain, may produce inaccurate impressions. There will be a temporary impairment in speech and mastication. Indications and contraindications. Indications. A dentulous or partially edentulous patient whose remaining natural teeth are indicated for extraction. Patients for whom complete extractions are required and aesthetics cannot be compromised even for a short period due to social and professional commitments. Contraindications. Patients with poor general health or debilitating disease. Patients who are poor surgical risks. Multiple extractions might be unwise because of systemic conditions like cardiac disease, uncontrolled diabetes, blood dyscrasias and those with slow healing potential. Emotionally disturbed individuals with psychological disorders. And cooperative patients. Conventional immediate denture workflow. 1. Diagnosis and treatment planning. Similar to any complete denture patient. Posterior teeth are extracted and impression procedures are started after a healing period of 6 to 8 weeks. To ensure optimal aesthetics and occlusion, if upper and lower immediate dentures are planned, they should be fabricated simultaneously. 2. Impressions. Preliminary impression, made with irreversible hydrocolloid. Preliminary cast is poured and custom tray is fabricated. Final impressions can be made using two methods: single impression technique, custom tray fabricated in autopolymerizing acrylic resin with spacer, 1 sheet of base plate wax, 2 mm, covering edentulous ridges, 2 sheets, 4 mm, covering natural teeth. Stops, 1 anteriorly and 2 posteriorly on either side in first molar area. Peripheral extension, 2 mm short of vestibule. Border molding of entire border using low fusing green stick compound. Interdental spaces between anterior teeth blocked out with wax. Final impression made with regular, medium body elastomeric impression material. Dual impression technique, sectional, pickup impression, custom tray fabricated covering only edentulous space and lingual surface of anterior teeth. Custom tray inserted and only edentulous section is border molded with green stick compound. Impression made of edentulous area and lingual part of anterior teeth using Zoe impression paste or regular, medium body elastomeric material. Tray handle cut off after material sets. Impression reseated and second impression made over the first impression in anterior teeth with a stock tray using irreversible hydrocolloid. Master cast poured in record base with occlusal rim fabricated for posterior regions. 3. Jaw relation records. Similar to conventional complete denture. Face bow transfer used to mount maxillary cast. Static centric record obtained at vertical dimension of occlusion and lower cast articulated. Eccentric records used to adjust condylar guidance on articulator. 4. Teeth selection and posterior arrangement. Existing teeth used as guide for size and shape. Acrylic resin teeth indicated, easier to trim, adjust. Posterior teeth arranged with tight, multiple centric contacts, bilateral balancing contacts in eccentric movements. 5. Try-in and arranging anterior teeth. Try-in. Posterior teeth try-in scheduled to verify centric relation, vertical dimension, and occlusion. Anterior arrangement, duplicating natural arrangement, alternate teeth cut away on cast. Labial portion of root excavated to 1 to 2 mm depth on labial side, flush with gingival margin on lingual, palatal side. Modifying position. Casts made edentulous in anterior segment and desired arrangement created. Cast trimming method, Gerby technique, Fig. 17.12, Step 1. Remove tooth at gingival level. Step 2. Recess socket 1 mm. Step 3. Labial edge recess to incisal third mark. Step 4. Midpoint recess to midwidth labial cut. Step 5. Round over lingual aspect of socket. Step 6. Round off labial to middle third, sand smooth. 6. Waxing, processing, insertion and post-insertion care. Waxing and processing. Waxing completed, processed, occlusal changes corrected prior to removal from casts, finished and polished. Insertion. Traumatic extractions performed. Clear acrylic surgical guide, fabricated on duplicated master cast, used to evaluate surgical site and identify pressure areas, shown as blanched tissue. Denture inserted, borders checked for overextension, gross occlusal irregularities corrected. Patient instructions. Wear denture continuously for 24 hours. Removing early will allow edema to prevent reinsertion. Avoid expectorating, gargling, smoking, hot liquids, alcohol. Apply cold packs, soft diet and cold drinks. Post-insertion care timeline, 24 hours. Denture removed, cleaned, tissue examined for overextensions, pressure spots, gross occlusal discrepancies corrected. Patient taught insertion, removal and instructed to wear at night for 1 week. 1 week, definitive occlusal correction. Tissue conditioners applied if necessary and replaced weekly. 1 month, clinical remount for occlusion refinement. 6 to 12 months, complete ridge healing, takes 8 to 12 months. Relining performed around 6 months. Interim immediate dentures. Indicated for periodontally involved natural teeth removable without surgical trauma. Procedure steps. Maxillary, mandibular irreversible hydrocolloid impressions made with interdental spaces blocked out in wax. 2 sets of casts poured. First cast, melted baseplate wax poured into impression teeth spaces up to gingival margin. Rest of impression poured in dental stone. Used to process denture maintaining original tooth shape. Second cast, poured entirely in dental stone for jaw relations, reference. Casts articulated and missing teeth arranged using acrylic denture teeth. Waxing done over flanges to vestibule and palate. Flasked and dewaxed. Tooth colored heat cure acrylic resin poured into tooth space, pink heat cure acrylic packed over base. Cured, deflasked, trimmed, finished, and polished. Teeth extracted atraumatically, denture inserted, tissue conditioner applied as needed. A new set of complete dentures is fabricated after 4 to 6 months. Comparison of conventional and interim immediate dentures. Feature. Conventional immediate denture. Interim immediate denture. Type. Definitive or long-term prosthesis, relined after healing, transitional, short-term, new dentures made post-healing, cost. Costs less, 1 denture plus relining, costs more, 2 complete dentures, treatment time. Longer, requires waiting for posterior area to heal first, shorter, all teeth extracted at same time, aesthetics. Cannot be easily changed. Can be altered when final new denture is made. Vertical dimension. May not be maintained as posterior teeth are removed first. Maintained as posterior teeth remain until insertion. Outcome. Patient ends up with 1 denture. Patient ends up with 2 dentures. Interim becomes spare.